طيب, you guys can see the screen, صح? Chat here. طيب, يلا, بسم الله. Those are the objectives for today's lecture. Basically, chest X-ray interpretation. It's a kind of exercise. So I would appreciate if you guys contribute as much as possible. Okay. Okay. I find this useful for me to imagine what's happened in the X-ray and what's the anatomical location for the major organs as well as vessels, which in black and white image like an X-ray may not actually be very clear, but when you see a bulging or whitening or ossification, you may expect from where they are coming from. So you can see the cardiac silhouette here. This is the right side. This is the left side. The great vessels area, basically all in the center, as well as the trachea and the esophagus. You see the branches of the venous system. So I always find it useful to know what's the anatomical location so I can imagine when I see an abnormality, which are the potential system it's coming from. Okay, this is in black and white, basically. So you guys see the spinal process here in the background. This is the clavicle all the way here. Those are the posterior ribs. هذول اللي جايات كده. These are the posterior ribs. اللي جايات على جنب كده. Those are the anterior ribs. This is the hilum area, left and right. This is the pulmonary artery area. This is the carina, which is the when the trachea go to the main bronchus, right and left. Left ventricle, right ventricle. This is the diaphragm, the right, and this is the left. This is the gastric bubble. This is what we call it costophrenic angle. This is the left one, and this is the right one. And don't forget the scapula. And if she is a female, we're also going to see the breast shadow all over here. Okay, this is just very basic chest X-ray locations. Okay. Okay. A comment about the AP and the PA of projection. So whenever the object is يعني, near the X-ray source or the light source, it may appear basically larger. Okay. So the close it is from the light source, or in this case the X-ray source, it may appear larger. And this is why we would like to do an X-ray from the posterior to the anterior. So the cardiac silhouette wouldn't be large because the heart is close to the anterior. Okay. Okay. So how do we assess the exposure, guys, from your radiology lectures? How do we assess the chest X-ray exposure? How we can determine it is a good exposure or poor exposure? What do you think, guys? Guys, are you back or am I talking to myself? Guys, I need your help. How can we assess the exposure in a chest X-ray? Compare it with clinical signs? Not really. Image quality, yes, one of the determinant for image quality is assessing the exposure. So the question is, how can we assess the exposure so we can determine the image quality. Body position, well, it's have nothing to do with the body position. Body position might be important in this being central, the chest X-ray being central, but doesn't determine the exposure. Okay, good inspiration. Okay, contrast, clavicle. Okay.
Penetration.
How can we determine the penetration? Contrast, those are a good try, but not really. Okay, guys, you see the spinal process here. تشوفون هذا الوايت dots over here. Is this clear, guys? تشوفون هنا 1 2 3 4 5. So behind the cardiac silhouettes, هذا الهارت, those spinal process will disappear. So they were there, but when you enter the cardiac silhouette, they are disappeared. That's meaning this picture have actually a good X-ray exposure, okay? The second is the rotation assessment, and a lot of you guys already alluded some of the way to assess the rotation. It's basically, you see the clavicle. So this is the spinal process, and make sure that they are actually a space between the spinal process and the medial aspect of the clavicle are equal in both sides, okay? So this is how you assess for the rotation. Those two, the rotation as well as the exposure, are determined for the quality of the image. And the third one is basically adequate inspiration. And how can we assess for adequate inspiration? We can do that by counting the reps, okay? So ideally, you would have roughly between 7 to 9 reps. Yeah, 7 reps is good. So 7 to 9 reps, as well as the presence of costopharyngeal angle in both sides. Those are very good answers. Allah يعطيكم العافية. Okay, so this is just an example of the PA and the AP. For the same patient, same exposure, and you can see the PA is more nice, more telling than the AP. Okay, so we're not going to go over how to approach a chest X-ray because you guys should know it by now, but this is just to outline that we have too many ways may people teach you about how to approach chest X-ray and how to do the interpretation. We have the A, B, C, D, E, F, G, H, I. You can see the mnemonic here. We have also the form of text, which is technical adequacy, cardiothoracic ratio, and CP angle, mediastinum, contour, and paravertebral, and then lung zones, and then hidden area. Also, you can do it inside out, outside in approach. The key is to be systematic. Find a way you like and then follow it. Don't just go all over the place, because if you do that, you're going to miss major points. You're going to miss major interpretation points that you should actually comment about. And this is both in real life as well as in the exams. Okay, so let's jump to the cases. We have a 60-year-old female. She has no significant past medical history. She is non-smoker, present to the emergency with 3 days history of fever, productive cough, and shortness of breath. This is her chest X-ray. What do you guys see? Someone mentioned consolidation. Be more specific, or as much specific as possible. So where is the consolidation? Imagine that you are talking to someone over the phone and you'd like to describe the abnormality. They don't have an access to the chest X-ray. So how would you describe it? Okay, someone trying saying left lung, lower lobe, lower consolidation. I like that. It's not in the lower actually. It's probably in the upper. And don't forget the left lung only have upper and lower. They don't have middle. And it's look like lower consolidation. Okay. That's good. Okay. So lower consolidation in the left upper zone of the lung. Okay, that's very nice. And what are the differential diagnoses for that? What do you think the diagnosis would be? What's the most likely diagnosis? Pneumonia. Good, good. I think the clinical context and being supported by the chest X-ray suggesting of pneumonia. So this is right upper lobe consolidation, liking pneumonia. And if you remember from last week, I always like to put all the lectures together, especially the one I present. So I think reinforcing the information will be useful. So the option we have, he came to the emergency, the antibiotic of choice would be beta-lactam, something like ceftriaxone, as well as azithromycin for atypical coverage, or fluoroquinolone, like levofloxacin or moxifloxacin, okay? Okay, case number 2, 50 years old male, past medical history is significant for hypertension. He is a smoker. He presented to the emergency department with a 3 days history of dry cough, shortness of breath, and pleuritic chest pain. Okay, remember, dry cough, shortness of breath, and pleuritic chest pain. This is his chest X-ray. What do you guys see? Someone mentioning lung collapse. Okay, in a lung collapse, what do you expect from the trachea to be? Do you think it would be shifted to the left or to the right in this case? اللي قال lung collapse. When the lung collapse, do we expect a trachea deviation toward the lung collapse or outward the lung collapse? Toward the lung collapse, that's true. And in here, we see it actually moving away from the lung collapse, okay? But that's a good thought. Someone mentioned tension pneumothorax. Where is the pneumothorax? So what's the color of the pneumothorax in a chest X-ray? Is it white or black? Black. And here we see it whitening. So it's unlikely to be pneumothorax, okay? And someone now mentioned also pleural effusion. I think someone mentioned it before, but we didn't reach it there. Excellent. So possible pleural effusion. But when you have an X-ray, you'd like to basically outline the abnormality, then try to reach the cause. So we see a whitening, or what we call it opacification in the left lower zone of the lung, okay? So we call it opacification. You are just describing the abnormality, okay? The top of the differential definitely would be pleural effusion. But other diagnoses like basically a consolidation from pneumonia also would give you a white abnormality, okay? But when you see it very white with no air, no black whatsoever, like it's completely white, you would expect it to be most likely pleural effusion. How can we confirm this is actually pleural effusion, guys? In an X-ray, or let's say using an X-ray technique. base of the lung. That's a good try. Okay, you guys know what decubitus chest X-ray meaning? That's meaning putting the patient in his side or her side during the X-ray, and when you do that, you expect the fluid to move. So instead of being here, it will be lying here. I wish I have an X-ray to outline that. But basically, the fluid move with gravity. Consolidation shouldn't move. Okay, so this is.
But it's actually hard to assess if it's less than 300 ml, an X-ray.
Do you think this is 300 or more? This is way more than 300, my friend. And if you see it while they are standing, you would expect it to see it when they lie in their sides, okay?
No, I didn't mention this picture. Is it less than 300 ml?
Oh,
I mean, the way to consider in the future, yes.
Okay, okay. So this is left pleural effusion. Causes can be parapneumonic effusion, empyema, or basically hemorrhage. Okay, case 3, 35-year-old female. She has no past medical history. She presented to an outpatient clinic with progressive worsening shortness of breath for 2 months with the constitutional symptoms. Constitutional symptoms meaning fever, weight loss, decreased appetite, those kind of symptoms, okay? And this is her chest X-ray. What do you guys see? Mass, right middle lobe mass, okay? So you see a mass, can be right middle lobe. What other area it can be? Good.
Halar metastasis.
Good, good. So those are the 2 areas you should consider. Okay, so this is anterior mediastinum mass, and the reason why it's usually there is no space between the mediastinum as well as the mass, but it can be middle lobe, absolutely. The differential diagnosis when it's anterior, and you know it's anterior because when you see the lateral, you don't see it in the middle, you don't see it in the posterior. So it's actually the localization is basically in the anterior mediastinum area. Okay, is this clear, guys? So here is the middle, here is the posterior. You actually see it in the anterior side here. What are the differential? We have them for short for the T's. It can be thyroid, which is basically retrosternal thyroid, teratoma, which is usually from birth, terrible lymphoma, just to remember, thymus, like enlarged thymus, as well as thoracic aorta, especially when there is an aneurysm. Okay, okay. This is just a picture to remind everyone about the possible pattern in the lung and the X-ray. So we have something we call the reticular. You guys see here, reticular. It's like a net, okay? And the other is nodular. Basically, it's like nodules, nugat, and then we have 2. We have nodules and mass based on the size. So those are an abnormal pattern in an X-ray. And it's good when you see an abnormality. They all, of course, are looking white or opaque in the chest X-ray. So whenever you find abnormality, it's good to describe it. Is it reticular pattern? Is it nodular pattern? Is it nodule? Is it mass? Okay. Okay. So what do you guys think about this X-ray? What is the pattern? The one on the left of the screen. Is this reticular? Yeah, this is reticular, okay? I just put it as an example. And how about this one? The one on the right of the screen. Nodular. That's good. Okay, so you guys know how that this is an example for reticular. This is an example for nodular. Okay. Okay. So you have a 49-year-old female presented with dry cough. This is her symptoms. Okay. So what do you see in the chest X-ray? And I give you 5 options. Is this a lung mass? Is this a mediastinum mass? Is this atelectasis? Is this an airspace? Is this an interstitial lung disease? And always accompany that by why. Why do you think this is number 2? Why do you think this is not number 2? Okay, so number 2. Okay, so you guys see this whitening, but also you see that there is actually a shifting in the trachea. Okay, so something is pulling the trachea toward the right side, and this is most likely to be atelectasis. Okay, why there is an atelectasis? You see this whitening here. Maybe this patient actually have some kind of malignancy or collapsing the bronchioles and leading to atelectasis. So this is, yes, whoever answered atelectasis, that is the right answer. Okay, and don't forget atelectasis can be a secondary from mucus block or cancer or anything can block the airway. Okay, so this is atelectasis. Causes can be mucus block, can be pneumonia, foreign bodies, lung cancer, or lymphoma. Okay, okay. So 58-year-old female awaiting for total hysterectomy as she's having abnormal menstrual bleeding. She's a smoker. They sometimes do a preoperative chest X-ray just to make sure that there is no abnormality, and this is her chest X-ray. What do you guys see? Always be more specific, guys. Someone mentioning nodules. Okay, where is the nodules? Okay, good. So someone mentioning nodules in the left upper part of the lung. You guys see it here. That's excellent. But also don't forget to see this abnormality in the center, okay? This suturing indicating that this patient already have a sort of heart operation, okay? Whether it's bypass or valve disease. So always when you see this and the history didn't mention that, make sure that this is the patient you're actually looking for, okay? Because sometimes you are looking actually at the wrong X-ray. So always comment about all the abnormality or anything doesn't fit your patient. And for example, this patient is female, but let's say the case was a male and you see a breast shadow, that's meaning probably it's the wrong X-ray. But overall, the abnormality here in the lung, you're absolutely right. It's a nodule in the left upper part of the lung, okay? What are the possible causes? Well, granuloma can cause that, lung cancer, lung mets, like a primary is not in the lung, or hamartoma, okay? Okay, how about this? 40-year-old female, she's African-American, she had no symptoms, she just had a routine chest X-ray, okay? For, let's say, annual checkup. And this is her chest X-ray. What do you guys see? I need your help, guys. What do you see? Someone mentioned abnormal hyaline. Which side? Which side you see an abnormality? Bilateral. Good. Okay. So what are the differential diagnoses for this lady? Asymptomatic, have bilateral hyaline, what look like lymphadenopathy. Okay.
Sarcoidosis.
Sarcoidosis, TB, good. What else? Those are a good differential diagnosis. Okay, infection, lymphoma, they're all possible, but especially sarcoidosis and TB possible, okay? So bilateral hilar lymphadenopathy causes include sarcoidosis, infection, TB, malignancy like lymphoma. Okay, good, good. Okay, how about this case? 62-year-old with productive cough, fever, and weight loss for 2 months. Whenever you see weight loss and some of those constitutional symptoms, pay attention. Those are a red flag, okay? This is her chest X-ray. What do you guys see? Describe. I need your help, guys, please. Okay, nodular pattern, okay, good. Where? I'm over the phone. I don't have an access to the chest X-ray. Is it in the right? Is it in the left? Is it in the upper? Is it in the lower? Okay, bilateral all over the place. Okay, what are the differential diagnoses? Giving the history and this finding.
Mets.
Okay, Mets for malignancy. Okay, good. What else? So malignancy, Mets, what else? Silicosis, okay. Okay. What else, guys? Those are a very nice differential diagnosis. Okay, so nodal pattern all over both lungs, granulomatous disease, miliary TB in particular, guys, giving the story, the fever, the weight loss. Sarcoidosis would be the other differential. And then we go to what we call it the pneumoconiosis with a co-worker pneumoconiosis, silicosis, and malignancy, whether it's METS or in particular also bronchoalveolar cancer. Okay, so how about this? 21-year-old male, tall guy presented to the emergency with a sudden onset right chest pain followed by shortness of breath. So pain, then shortness of breath. This is his chest X-ray. Describe what do you see? I would like description, guys. Okay, bilateral. No, this is probably talking about the what do you guys see? I need your help. This patient is in the emergency department complaining of shortness of breath after having a sudden onset right chest pain. What do you guys see? This guy is asking you, doctor, what's wrong with me?
Pleural line.
I am 21 years old and I have chest pain and I have a shortness of breath. This has never happened in my life. What's going on, doctor? Sorry, you were saying something? Someone over the headphone?
Pleural line.
Pleural line. What do you mean by pleural line? My apology. What do you mean by pleural line? Bilateral reticular pattern. Okay, I know what you're talking about. Although if you focus, looks like an overexposure picture, okay? Because you see those spinal process behind the cardiac silhouette, you shouldn't see it. But I understand this خلينا نقول reticular pattern you're talking about. I think it's all from overexposure, but that's a nice comment. And someone above mentioned consolidation in airway. What do you mean by consolidation in airway? My apology, I don't understand that. Someone is asking, is there right pneumothorax? You tell me. You help me interpret this X-ray. I don't have access to X-ray. I don't see it. Tell me what's the abnormality there. Help me out, guys. Okay, also it could happen in a patient live in an area with lots of dust for a long time. I guess so. I don't know if they're talking to each other. So I'm not following. Okay. Okay, guys, what do you see in the X-ray? So what's the clinical context suggesting? Yani without looking at the X-ray, a clinical presentation suggesting of what diagnosis? A young presented with a right chest pain followed by shortness of breath. What does this presentation suggest? What are the differential diagnoses crossing your mind? Okay, I will give you guys a clue. This might be a life-threatening situation. So recognizing the abnormality in the X-ray may save life and may facilitate an early intervention. Okay? Okay, guys. Focus with me. Okay? خلينا بس بحط هذا شوي بالشات. I will lower it a little bit. And I'd like you to focus with me in this X-ray. This is an important X-ray, can save life in practice. You should recognize it يعني as soon as possible. You guys see this X-ray. You see the left lung. Let's start with the normal one. You see the lung tissue. اللung tissue معناته فيه white وفيه black. Okay, في white وفيه black مع بعض. Okay, and you see some couple of here what look like a bullseye. Okay, but you see the lung tissue all over the lung here. كل اللung هذه فيها lung tissue. Okay, let's go to the right side. لما تمشي على الرايت side, the lung tissue will stop right here. هذا lines, the opaque line, basically beyond it, lateral to it, you see no lung tissue. ما في lung tissue هنا. كل هذا ما تشوف فيه lung tissue. This an indication that there is actually a pneumothorax outside the lung, pushing the lung medially. Okay, so actually the lung here is collapsed, and the pneumothorax is contained from the top all the way to the bottom of the lung. So this is actually a massive, this is actually a large pneumothorax. Definitely can lead to tension pneumothorax. Is this clear? You guys see this line? وضح لكم اللاين هنا. والabsent of lung tissue lateral to it. Is this clear, guys? مهم جدا 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 تعرفون how the pneumothorax look like in a chest X-ray. Basically, you don't see a lung tissue, ما في lung tissue, and if you pay attention, you actually may able to see basically an opaque line كده حد فاصل. Medial to it, you will see the lung tissue. Lateral to it, you will not be able to see a lung tissue. Okay. This is what's one of your colleague mentioned. This is basically the lung. Hello, but the X-ray technician gave the chest X-ray overexposure. And overexposure idea is to make the pneumothorax more clear. Okay, so sometimes a technician they're not gonna يعني plan to do a perfect خلينا نقول exposure or خلينا نقول medium exposure. They may sometimes give overexposure because a doctor they ask them to give overexposure to try to identify a pneumothorax more clearly in the chest X-ray. Okay. Okay. Fine. Good. Good. So very simple. This is pneumothorax. Okay. You guys can hear me clearly? Guys, can you hear me? Good. Okay. Next, 42-year-old female known to have an end-stage renal disease. She's in hemodialysis, IHD, intermittent hemodialysis. She presented to the emergency with a progressive dyspnea and chest pain. Okay? Okay. So this is her chest X-ray. What do you guys see? We have a lot of good suggestions here, guys. Cardiomegaly, absolutely. Massive, 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 massive. Water bottle thing, maybe shape. Yeah, it looks like water bottle. كده كبيرة. Good. Pericardial effusion. Okay, that's one of the differential diagnoses. There is a central line. Excellent. Someone already mentioned about this portal catheter. Someone mentioned بس في شيء غريب. There is a lot of things strange in this X-ray. This is abnormal chest X-ray. Okay. Okay. But those are a very nice suggestion. There is a water bottle shape. There is a cardiomegaly. What look like also pericardial effusion. Excellent, excellent, excellent. Okay, so large pericardial effusion, inflammatory post-heart surgery or heart attack. Those are the causes for pericardial effusion. So it can be from inflammation after heart surgery or after heart attack, after MI, autoimmune disorder like rheumatoid arthritis, lupus, metastasis from lung, breast cancer, infection, uremia. And don't forget this patient have a end-stage renal disease, so it can be uremia. Okay? Okay. Okay. Another case, guys. 53-year-old smoker complaining of chronic cough following a bout of pneumonia. Okay, sorry. 53-year-old smoker complained of chronic cough following bouts of pneumonia. So he had recurrent pneumonia. He had expectorate purulent sputum. He is always making sputum. This is kind of just to give you a clue. He have what we call a tram track visible in chest X-ray, and I will show you what's tram track meaning. هذا tram track حق الترين. You guys see it here. تشوفونه هذا واحد هذا اثنين هذا اللي بينهم. So this is actually indication for bronchiectasis basically. Okay. And when you have bronchiectasis, you're going to make tons of amounts of sputum. Okay, time for question, guys, for any of the chest X-ray. Question, question, question. شباب عندكم أي أسئلة؟ Okay, last piece of advice, guys. All the abnormality we talked about today, they are common and you should be familiar with, okay? So if you would like my advice, take at least the abnormality. For example, we talked about pneumothorax, and just go over all the textbook you have, all the X-ray you have, even just type it in Google or whenever trusted resources you have, and then see a variation of that pneumothorax. So you can get your eyes trained to discover pneumothorax. The same with pneumonia. The same with tram track. Tram track معناته هذا الخط حق الحديد، خط الحديد. Causes, it's just a bad infection usually in the bronchioles lead to this tram track shape and can lead to what we call it bronchiectasis, okay? It's basically a destruction for the normal airway shape, okay? Indicated of what? Indicated of bronchiectasis, basically, okay? Okay, any other question, guys? Please, please, please go all over the X-rays, see other normal, other variation, because don't expect all the patient will have exactly like this pneumothorax. Sometimes they're only gonna have it in one side. Sometimes you're only gonna be contained in, let's say, the upper part, though, because don't forget it's air, so air usually will accumulate in the upper part of the lung, as well as with pneumonia. You will have tons of examples for pneumonia, so get your eyes trained for that. Thank you so much. And of course, if you have any difficulty interpreting a chest X-ray, just send it to me. We can review it after any coming lectures. الله يعطيكم العافية جميعا.